Hi everybody, my name is Bobby Kelly. I am a family physician by training and a board-certified addiction medicine physician. Today we're going to be talking a little bit about opioid use disorder. This module is meant to be a supplement to another module, SUD 101, given by my colleague Dr. Sarah Slocum. We will refer back to some of the concepts that were reviewed in detail during that module. I recommend you may want to go back and review that as well, but of course you can view them in any order. My hope is that by the end of this module, you'll leave with a better understanding of opioid use disorder, which we'll call OUD. And for those of you who are not familiar with that term, it is what you may think of as addiction, and in this case, specifically addiction to opioids, which are things like Percocet, morphine, or even heroin. I want you to leave understanding OUD as a chronic disease, and that, like other chronic diseases, there are evidence-based strategies for successful treatment. We'll also plan to explore some of the neurobiology and physiology behind the disease, which will hopefully help us better understand how treatment can be successful. And finally, I hope to be able to dispel some myths about people with OUD, as well as the disease itself. Let's start off by discussing the importance of thinking about opioid use disorder as a chronic disease. Dr. Slocum discussed diabetes as an example of a chronic disease, and I'm going to give you another example. Think about CHF, or congestive heart failure. We know how to treat congestive heart failure with evidence-based medications for the outpatient, but we also know that many people with CHF, especially after a salty holiday meal, may wind up in the emergency department with lots of fluid on their lungs, having some trouble breathing. We know that this is something that is a part of the chronic disease model, and we help these people in the emergency department. We give them medications, we discharge them with the plan, and we see them up again in follow-up in the outpatient world. We meet them where they're at, and we continue to take care of them. It's important to understand that this is how we should be treating people with opioid use disorder. We don't need any more data or any more evidence. This is the bottom line. Opioid use disorder is a chronic disease that has evidence-based treatments which support recovery. We know it's the case, and now it's our job to spread this information. So let's start with the definition. Opioid use disorder, put simply, is a chronic medical disease defined by abuse or misuse of opioids despite harm. Sadly, for the last half a century, the way that OUD has been historically managed is with the goals of rescuing emergencies, including overdoses and serious complications, offering patients IV fluids, a sandwich, a pat on the back, and the advice of, it's important to stay clean, discharging them from the ER or hospital and hoping they won't wind up back in the same situation later that week. Ask any person working in the ER, and they can tell you how unfortunately common it is that people with OUD can repeatedly show up in the ER overdosing from opioids, only to wind up ultimately dying from a fatal overdose. This is not okay, and we can do better in medicine. We have all heard about the opioid crisis and the increase in opioid-related overdose deaths over the last 20 years. Unfortunately, this trend has only continued to worsen. While the rates were unacceptably high 15 years ago, they have now reached critical levels that demand that all of us in the healthcare world act to reverse it. New Hampshire has the unfortunate distinction of being consistently in the top 5 states in the country with the highest per capita overdose death rates. This is not a statistic we should be proud of. One of the most common drugs on the illicit drug market is fentanyl. I'm sure you've heard of it. It's a synthetic opioid which can be legitimately used to treat chronic or acute pain in a medical setting. It is 100 times more potent than morphine. Just to put that into context, 2 milligrams of fentanyl can be lethal depending on the body size of a person, their tolerance, or their past usage. As a drug, it's synthetic, easy, and relatively cheap to manufacture on the illicit drug market in labs. And it's unfortunately often mixed into other substances sold on the drug market, cocaine, marijuana, heroin, often at inconsistent doses. The DEA found that almost half the pills tested for fentanyl contained more than 2 milligrams of fentanyl. Drug trafficking organizations distribute fentanyl by the kilogram. 1 kilogram of fentanyl has the potential to kill 500,000 people. Let that sink in, please. It's no surprise then that synthetic opioids are the primary driver of overdose deaths in the US. CDC data between 2020 and 21 showed that the overdose deaths involving opioids rose almost 40%, and that overdose deaths involving synthetic opioids, mostly fentanyl, rose over 50%, the primary driver to increase total overdose drug deaths. For many people with OUD, they were introduced to opioids through legitimate opioid prescription for pain, either from surgery or injury. So how effective is opioid use disorder treatment? The death rate for people with OUD is 6 times that of the general population. Now, with appropriate outpatient medical treatment, we are able to bring that person's death rate down more than 3-fold to 1.7 times the death rate. This is remarkable and something that every person in the medical industry should be shouting from the rooftops. But as of 2022, only 25% of the people who could be on OUD treatment are receiving treatment. There's several barriers to this. Much of it is stigma. Some of it is need for increased education. If you had any doubts about the effectiveness of opioid use disorder treatment, take a few other common medical examples that we see every day in medicine for comparison. Basically, every person with an asthma exacerbation seen in the ER is treated with steroids, and it takes, on average, a treatment of 9 people with steroids to prevent a hospitalization. That's called the number needed to treat. For treatment for stroke or heart attack with aspirin, the number needed to treat is 40, but we discharge almost every patient with these conditions on aspirin appropriately. The number needed to treat with buprenorphine, a medication for OUD, which we'll learn about in a little bit, is 2. 2. This may be the record for the lowest number needed to treat I've seen. As I suggested earlier, the answer to this opioid epidemic is not a simple one. In addition to the medical treatment of OUD, we need to help address the stigma that exists. Treatment for people with OUD is not always a linear process. These people have rewired brain circuitry that is part of the disease, and it can be hard to see things rationally. In addition, many people may have poor social supports, disrupted family relationships, financial struggles, legal problems. As healthcare folks, we can get frustrated thinking it's a moral failure or intentional. The reality is there will be obstacles, most likely relapses. We'll talk a bit more about the harm reduction model later. Treatment goals may differ from patient to patient. For some, they may be complete remission. For others, simply staying alive. I like this quote from Dr. Todd Corthius, who is a professor of medicine at Oregon Health and Science University. He says, "The easy part is learning about and administering buprenorphine. The hard part is changing the clinic culture to say, opioid dependence is a brain disease. We need to curtail the notion that these patients are different." Okay, now let's talk a little bit about the anatomy and physiology of OUD. Having a better understanding of what's going on in the brains of people with OUD can definitely help demystify a lot of this and hopefully address some of the frustration that many of us feel. As a reminder from the earlier module, SUD 101, we've learned a little bit about the neurobiology of what happens in addiction. We learned about the limbic system, the primitive forebrain, that is responsible for that fight or flight response, and the pleasure center. Think limbic system, pleasure center. It's typically kept in check by the prefrontal cortex. Think of that as the decision maker, moderator of social behavior. It keeps things in check. But people struggling with substance use disorder, or OUD in particular, the balance of reward, motivation, learning, memory, inhibition can be completely disrupted. That braking system, which typically keeps people in check, gets turned off. And often patients with OUD start doing things they never might have ever done before in order to maintain a high, or often simply to prevent withdrawals. Things such as lying or stealing from loved ones, buying illegal drugs off the street. A person is simply trying to make sure that they can prevent these withdrawals. And this disruption is often associated with the problematic behaviors of addiction that we think of. Next, I'm going to talk a little bit about the reward system that's in our brains working every day. It's called the dopamine system. We looked at this a little bit at Dr. Slocum's lecture at the microscopic level. Normally, this system is a reward system. Think about a runner's high. When somebody goes exercising, they feel a reward, a pleasurable response often, and this is sometimes known as the runner's high. This positive reinforcement can be healthy. But for somebody who has the propensity to develop OUD, after taking an opioid, the brain is flooded with this happy hormone, dopamine, which results in what we think of as the high associated with drugs. With that flooding of dopamine in the brain, it reinforces the person's desire to use again and again. It's an example of a classic positive reinforcement gone awry. And when it does, it's very difficult to become free of the vicious cycle of withdrawal and cravings. Over time, people require more of the drug to get the same high, which is called tolerance. We'll refer back to this in a little bit. Opioids have their effect on us through something called receptors. Think of it as a keyhole. There are different size and shaped keyholes in the body where the opioids can fit into. Not all opioids affect each keyhole or receptor equally or in the same way. We're going to focus mostly on one receptor, the most relevant and important receptor for this talk. It's called the mu receptor. The effects of opioids on the mu receptor include sedation, slow breathing, diminished consciousness, and mood alteration. The main effect that most of us are familiar with is pain relief or analgesia. Each opioid has a different profile for how they attach to these receptors, how sticky they are, how much they fight to stay on them. We call this the affinity. This, in turn, categorizes opioids into different types. On one end, we have something called full agonists. They fully activate the receptor or turn them on. On the other end, we have something called full antagonists that fully block or prevent from turning on. And in between, we have a mixed agonist or antagonist, buprenorphine. It blocks some and it activates others. It's this uncanny relationship to the receptor that makes buprenorphine an important tool to treat opioid use disorder. We'll get more into this in a little bit in the treatment section. Okay, now that we have some basic foundations about the science behind OUD, we can focus on diagnosis and treatment of OUD. For those of us who are not clinical, I will try to be as foundational as I can without getting too much into the weeds. For those of us who are clinical, if you desire any more detail, there are plenty of additional resources through organizations such as NAMI or SAMHSA. We're also trying hard to make lots of these resources available internally here at Exeter. Let's start off with how OUD is formally diagnosed. As a reminder, OUD is a chronic medical disease using certain criteria. The three most important criteria to remember are cravings, tolerance, and withdrawal. If you have any combinations of these three, the chances are that you're suffering from OUD. Cravings are a strong urge to use the substance, almost a compulsion to doing so. Tolerance is needing more to achieve the same effect. And withdrawal syndromes are negative physical and emotional side effects that occur when opioids are no longer in the system. We'll talk a little bit more about that later. You could think of someone with OUD as typically being in one of three states. One is the status quo. Their mu receptors, those keyholes, are filled with the opioids that they are used to having in their system. And typically, for the most part, these people are functioning. The second state, at one extreme end, is intoxication or overdose, where there is more activation of those receptors than typical. At the other extreme end is withdrawal, where those receptors are not receiving the activation they are used to. Let's talk about some of the symptoms of overdose or intoxication of opioids. These people are incredibly slowed down. Think about the extreme exaggeration of each of the effects of that mu receptor we talked about. Their bodies are in slow motion. Their blood flow is in slow motion. Breathing is slowed down. Their oxygen exchange is slowed down. And as a result, their body is cool, clammy. Their skin and their fingernails are blue. The pain relief properties of the opioids are exaggerated. Think almost too comfortable. At the other end of the extremes are the withdrawal symptoms. In many ways, it's the opposite of overdose. First, it's important to remember that people in withdrawal feel like they are going to die. The urgency to seek relief for these people can be overwhelming. Coupled with the lack of inhibition that we mentioned earlier, this can lead people to do things that they've never done before, like steal, break into things. Withdrawal from opioids is rarely fatal, unlike alcohol or benzos, but it is very uncomfortable. The symptoms of opioid withdrawal fall into a few buckets based on time. Typically up to about 72 hours after the last dose of opioids. Depending on the kind of opioid, these initial physical symptoms start and then peak. Left untreated, these physical symptoms begin to lessen after about a week, but the other psychological and emotional symptoms such as depressed mood, irritability, trouble sleeping can last for another 1 to 2 weeks. Without additional treatment, many people experience cravings and depressed symptoms for weeks to months afterwards. We will see later that treatment with buprenorphine is best initiated when a person has begun to feel the moderate withdrawal symptoms in that first stage of withdrawal, typically around 6 or 12 hours after last using. We have a formal scale which helps categorize levels of withdrawal symptoms. It's called the COWS, or the Clinical Opiate Withdrawal Scale. The scale measures physiologic and self-reported symptoms that help us to put the patient's experience of withdrawal on a continuum. Thankfully, we don't need to wait until somebody presents to the ER with signs of a life-threatening complication in order to diagnose OUD and introduce a patient to treatment. There is something we can do right now. It's low cost and relatively easy to implement, and that's screening for opioid use disorder. There are several validated screening tools which can be used in any clinical setting that can help identify people with substance use disorder and opioid use disorder. There are resources available on the NIH website if you screen positive, including starting medications, which we're going to get into next. Now let's talk about something that we can do right now to help address this overdose treatment. There is a medication called naloxone, often known as Narcan, that is given to help reverse overdose, and it can be given in the nose or in the veins. It's very effective. Congress recently made this drug over the counter, so it will be soon available at local pharmacies all across the country. Every person with OUD, or a person who's on chronic opioids, or family or friends of people with OUD should have access to intranasal naloxone or Narcan. As I said, it is now over the counter, and I encourage everyone to become familiar with how to administer this life-saving drug if ever needed. While I'm thrilled we will have more access to the opioid reversal drug, Narcan alone is not the answer. I don't know about you, but I'd rather not continue with this cycle of bringing back people from the dead without connecting them with treatment to help prevent future overdoses. Here's a sobering statistic. For somebody whose overdose was reversed with naloxone, they have a 10% likelihood of dying in the next year. Of those people who die, 10% of those died within 3 days. Now let's compare that treatment with a treatment of another condition that we're very familiar with, cardiac chest pain. Somebody comes to the emergency department and they have a similar risk of dying, 10%, we would never send them home. Those people would be admitted, they would have a cardiology consult, they may even go to the cath lab. But sending home patients, that's what we do with people with opioid use disorder, and we need to change that. Treatment for OUD can be very successful, but it doesn't occur overnight. A 5-day detox, even a 30-day detox, doesn't give enough time for the brain to fully heal, for all those neuroadaptations to change. It can take months or years to undo the changes made in the brain. I like to think of as two parallel things happening in OUD treatment, especially in the beginning. While the medication hopefully starts to break the cycle of cravings and withdrawals, it gives the brain time to heal and recalibrate itself. There are 3 main medication strategies that treat OUD: methadone, naltrexone, and buprenorphine. Methadone is a long-acting, full agonist, or activator. Remember, it turns on the receptor. Only available through specific opioid treatment programs, and it's a highly regulated drug. Naltrexone is a full antagonist, or a full blocker, which is either taken orally or intramuscular in a needle, and it blocks the receptors, which can help address the cravings and the addiction cycle. And then we have buprenorphine, which, as I mentioned earlier, is a mixed agonist and antagonist. Full agonists carry several risks, including serious overdose potential. So while methadone, while a very good medication, also carries with it cardiac risks that require monitoring, as well as the serious overdose potential. On the other hand, naltrexone is an extremely safe medication, but it doesn't work for everyone, since it only serves to block the opioid receptors. Finally, as I've alluded to, buprenorphine has some unique characteristics that help make it a very special medication to treat OUD. The rest of this module will be talking more in depth about buprenorphine, or often shortened to bup. For starters, it has a ceiling effect, which means it's extremely safe and there's minimal risk for overdose given its limited respiratory effect. It has a very strong affinity for the opioid receptors. It has that really tight and sticky bond. It's a partial agonist, so it activates the mu receptors just enough to avoid withdrawals and reduce cravings. But it's also a partial antagonist, so it doesn't cause a high. It lasts longer in the system than most illicit opioids, which also helps to prevent withdrawals. And you can prescribe with just a regular DEA license. So once again, buprenorphine does not cause euphoria, does not cause a dopamine surge, doesn't cause the respiratory depression, cognitive depression. Guess what? You can't overdose on a buprenorphine. But what it does do is prevent withdrawal symptoms, cravings, overdose, and pain. There are 3 phases of treatment with buprenorphine: induction, which is starting buprenorphine, stabilization, adjusting buprenorphine, and maintenance, maintaining bup. The induction phase lasts about 1 to 2 days, and most experts recommend something called a home induction, where a patient is given medications that they can bring home with clear instructions and follow-up. The second phase, stabilization, takes a few weeks, and this involves adjusting the medications with some short interval visits with the provider to discuss what's the right dose for the patient in the long run. And the last and most important phase, in my opinion, is the maintenance phase, and that takes as long as it takes. Just like insulin for diabetes or Zoloft for depression, it's a medicine that will be in the patient's medical chart for as long as it takes. You taper off when it makes sense, you restart if needed. I'll provide just a brief comment on induction, or that beginning phase of the treatment that we mentioned, since there are lots of informational modules on this topic. But as I mentioned earlier, ideally the treatment with buprenorphine starts when a person is in moderate withdrawal, so usually between 6 and 12 hours after a person last uses opioids. The initial dose of bup can help with some withdrawal symptoms, while other symptoms may need to be managed by other medications, such as compazine for nausea or dicyclomine or Bentyl for abdominal cramps. The most common form of buprenorphine is sublingual, or under the tongue. It's important to remember that this strip is not swallowed, it's absorbed under the tongue slowly. Buprenorphine is often sold as a combination product that also has naloxone in it. Now, I know this can be confusing, since naloxone is the drug Narcan that we talked about earlier, or that rescue drug. The naloxone component in the combo drug is actually not absorbed very well orally, but it was designed to prevent abuse of the med if crushed or injected. When someone in the maintenance phase of treatment with buprenorphine comes into the hospital or urgent care with a medical need, it's important to remember that we really should strive to continue the medication buprenorphine if possible. I like to think of it as their baseline. In a person in the maintenance phase of treatment on a certain dose of buprenorphine, whether it's 8 milligrams twice a day or 12 milligrams once a day, this person is stable. Their OUD is controlled and they don't have cravings or withdrawals. So if someone is coming in for medical treatment, continue it as you would with their depression medication. We gotta be honest here, people with OUD can experience pain if they're in a car accident or if they're having elective surgery. The recommendation for folks who are having elective surgery is to provide non-opioid pain medication as much as possible, such as NSAIDs like Motrin, ibuprofen, acetaminophen, other therapies like nerve blocks. In a person with mild to moderate acute pain, you can do the combination and maybe increase the sublingual buprenorphine if needed, giving divided doses 2 or 3 or 4 times a day, but no more than 32 milligrams a day. If a person has moderate to severe pain, in this situation it can be tricky. You may want to consider consultation with either a pain specialist or an addiction specialist. There's something called the harm reduction model in philosophy, which I mentioned earlier, that I want to explain a little bit about now. It's an approach to working with patients with OUD, and it focuses on practical strategies at showing respect for people who use drugs. In general, The harm reduction principles acknowledge the ups and the downs of recovery we reviewed earlier. It's important to think it's not 3 strikes and you're out. There's the concept of there's going to be ups and there's going to be downs. There may be relapse. You might have heard about the needle exchange programs in some communities, or even safe injection sites. It's important to remember that complete abstinence may not be a practical goal for everyone in recovery. We must meet patients where they're at and what recovery means to them. Think about that patient with diabetes or high blood pressure. We can set goals for our patients, but in the end, we must meet them where they're at. Here at Exeter, we're working to improve care at an organizational level by creating modules like this to improve education. We have an MAT program here at CORE, and we're also working hard to increase the accessibility of Narcan in our organization. Since data supports the integration of treatment of OUD into general medical care, this means that we need to improve clinician comfort with treating OUD and with these medications ASAP. As we have seen earlier in this talk, lost time is lost lives. Everything I talked today is evidence-based. And so, if you believe in evidence-based medicine, you will leave today knowing that opioid use disorder is a chronic disease, that we have safe and effective medication that is available today for our patients, and that people can recover and live in recovery and live healthy lives. Thank you so much for listening, and if you have any questions, please contact me or anybody on our team. Thank you.